So, CheckMate 577 originally presented the data at ESMO 2020 with disease-free survival, where we showed a doubling in the median disease-free survival from 11 months to over 22 months with a hazard ratio of 0.69. And now we presented yesterday 5-year overall survival data after a minimum follow-up of 5 years, should I say, the first analysis of overall survival. And we showed that there was a 16.4-month improvement in overall survival in the nivolumab arm versus in the placebo arm. It didn't quite meet statistical significance, but it was very clinically meaningful. If we looked at some of the different subgroups in that particular top-line result, we showed that CPS seems to matter in early stage disease like it does in the metastatic setting, where patients who have a CPS less than 1 were not really deriving much benefit, whereas those with CPS greater than equal to 1 had a survival benefit, a hazard ratio of 0.79. Now, the good news is that makes up about 90% of the patients. We also saw that esophageal squamous cell carcinoma patients did well. GE junction, probably not so well. I think that is a space where we're moving away from radiation and we're offering perioperative chemotherapy, plus or minus immune checkpoint inhibitors. And then finally, in the esophageal adenocarcinoma space, I think PD-L1 will matter there. I think CPS greater than 1 will be important. And doctors can have a decision around whether they would like to give chemoradiation, but they would need to give adjuvant nivolumab post the cross regimen if they felt that was a better option. I think for the majority of patients who may be fitter and younger, there may be a more aggressive approach with perioperative chemo plus or minus IO there. But there's some patients that just won't tolerate that perioperative flot. And so here I think the data is showing that if they're certainly CPS greater than 1, they do derive a good benefit from adjuvant nivolumab for a year post trimodality therapy. Yeah, so in this study, we did look at number of anatomical locations and histology. So as we saw, GE junction, not deriving great benefit there. The hazard ratio was 1.14, whereas esophageal cancer, the hazard ratio is 0.69. So we see that, I think for GE junction patients, perioperative chemo plus IO there will be the new standard of care. I think in esophageal cancer, certainly esophageal squamous cell carcinoma, we saw a 19-month improvement in overall survival. So still a very good option to do chemoradiation, followed by surgery, followed by adjuvant nivolumab. And then in that middle group, the esophageal adenocarcinoma group, we saw, I think CPS will matter. If you're less than 1, we didn't see great results, hazard ratio 1.4. But if you were CPS tumor was greater than 1, hazard ratio there was 0.79, indicating that really, as a single agent, it makes sense. You need an immunologically hot tumor rather than a cold tumor. So I think that'll be important moving forward. Overall, it's a really well-tolerated regimen, and I think we saw 86% of the patients achieving greater than 90% of dose intensity, which means the vast majority almost had the whole year of treatment, which is unlike post-operative chemotherapy, where we know the vast majority can't tolerate post-operative chemotherapy at all. In fact, it's less than 50% complete the entire regimen. So overall, this is very well tolerated. The quality of life was very good compared to nivolumab versus placebo. They were almost the same, which is really good. We didn't see any major toxicities that were new. There was no deaths on study, which is also reassuring. So overall, I think a very well tolerated regimen for patients, and certainly a good option for those that really don't have, who may be slightly a bit older or may not tolerate high doses of chemotherapy. Well, that was the design of the study. We purposely excluded the 25 to 30% of patients who achieved a pathologic complete response to chemoradiation. And so this was a high-risk group. And if you even look at the lymph node status, greater than 58% of the patients were lymph node positive, which again, high-risk group. All of them had residual disease. We didn't include anyone who had a PAT-CR. Now, they all had to have an R resection, R0 section, but these were all patients who had residual disease at the time of pathology assessment. So it's a high-risk group. To answer your specific question, what about giving adjuvant nivolumab to patients who have a PAT-CR? We don't have the data on that. Now, that was not the design of this particular study. We do have other phase 3 trials in this space, not post-chemoradiation, but they are post-chemotherapy in the perioperative setting. They will be evaluating whether patients with a PAT-CR achieve a benefit. We've seen in other tumor types that if you're MRD negative based on liquid biopsies, maybe there's not a great benefit from giving additional treatment, but we don't have that data in esophageal gastric yet. That's what I'll be really looking forward to from some of the correlative studies, the biomarker work, and some of the perioperative studies. Who's deriving benefit from the adjuvant space? And hopefully they've collected the ctDNA or the MRD assays there for us to determine who needs more treatment and who we don't need to treat, because we need to avoid over-treatment and under-treatment. I think some of those new assays will help us with that. We don't have that data from CheckMate 577. The study was designed approximately 10 years ago, so we didn't have the ctDNA collected, but the newer studies have that. Well, today at the ASCO plenary session, we're going to hear about the Matterhorn trial, which is a phase 3 trial looking at perioperative chemotherapy with FLOT plus durvalumab. And so we've heard it's a positive trial. We'll see the data later today. And I think that will be a very new and excellent addition to our treatment landscape. Well, I think it's yet to be determined. I think moving forward, what we've seen, we have seen a slight move away from low-dose chemo to higher dose of treatment. So I think that's a key take-home. We specifically designed CheckMate 577 to add nivolumab as the systemic treatment, but it's likely we will add additional chemotherapy on top of that. That's one of the strategies in the perioperative setting where they're giving perioperative FLOT plus Matterhorn. So we'll see. Hopefully that's the new normal where we're able to give patients a better chance of a longer term overall survival. But I anticipate in the future we'll move forward with adding targeted therapies on top of a perioperative chemo plus PD-1 backbone. And we'll see if that continues to improve overall survival. I'm not sure the future of radiation with chemo in terms of phase 3 clinical trials. We may not see too many more of those particular studies, but the take home is in patients that have esophageal squamous cell, this is still the standard of care. In patients that are borderline for FLOT or who do not want high-dose chemotherapy, this is still a very good option. So now what we're doing is we're giving our doctors around the world choices to help their patients achieve optimal outcomes.